This podcast is intended for veterinary professionals. Whilst members of the public are welcome to listen, please note that the discussions are designed with a clinical audience in mind and may include technical or treatment-related content. If you are a pet owner with questions or concerns, we always recommend speaking directly with your own veterinary surgeon who knows your animal best.
So welcome to today's episode of the Nupsala podcast. Today we are absolutely privileged to welcome Matt Gurney from the Zero Pain Philosophy. Matt is an internationally respected anaesthetist, a specialist in anaesthesia and analgesia, and Matt trained at the University of Liverpool. So Matt is passionate about pain management, lectures on the subject globally, and is an author of many international anaesthesia publications. He's the past president of the European College of Veterinary Anaesthesia and Analgesia. In 2020, Matt was awarded the Fellowship of the Royal College of Veterinary Surgeons for meritorious contribution to clinical practice. Matt's currently based at Eastcott Referrals and is a co-founder of the Zero Pain Philosophy. Now, that introduction was very difficult to say. There's some very big words in there for a Friday morning, but we've done that successfully. So, Matt, welcome. Thank you for joining us on the podcast. It really is a privilege to have you on.
Thank you so much for the invitation. I always love sharing knowledge on pain, and it's brilliant to be invited on your podcast.
Oh, that's fantastic. So, September is Pain Awareness Month, so we thought it was really fitting to have you on. This is a passion of mine as well, and so I'm really interested to know why you decided to go down this route as a vet, starting out at Liverpool University. What was it that really drew you to anaesthesia and analgesia?
I started life in practice working in a mixed practice, and I was always really interested in getting greater knowledge in one particular area, but I didn't really want to give up the mixed side of life in practice because I liked dealing right across the species, but I recognised there's a real art to mixed practice, and for me, I wanted to be good at one thing, and I think it's really hard to be good at one thing. I've got so much admiration for people in mixed practice that can juggle all of those plates. Yeah. And I thought, right, okay, what can I do? I thought about ophthalmology, I thought about cardiology, I thought about anaesthesia as the kind of specialties where you could still keep your hands across the species. And I kind of landed on anaesthesia more out of luck, really. There was an anaesthesia residency advertised at Liverpool where I had graduated from. I applied for it and I was successful in getting the residency. So as people say, the rest is history. And I didn't think much further about a career in ophthalmology or cardiology. Went back to Liverpool, loved the mixed aspects of it. Half of my residency was equine, half of it was small animal. At the end of 3 years, I developed a real interest in pain management, and small animal pain management was where I recognised that I wanted to focus my career. And yeah, I worked exclusively in anaesthesia and pain management since, and most of my work now is solely pain management. Yeah, so that's been the evolution over, it was 22 years since I graduated. Yeah, suddenly had that realisation.
Yeah, we don't think about that too much. So can you tell me, what is the Zero Pain Philosophy then?
Yeah, so Zero Pain Philosophy is an educational resource for vet professionals, and by vet professionals I mean vets, nurses, vet physios, and we have a global audience. So our website has free pain updates, we've got our free podcasts, we've got free nerve block videos, and we've also got paid for content that includes webinars, telemedicine consultations, and we have our accreditation scheme, Zero Pain Practice. And I realised I was spending a lot of time doing CPD for other people. And you do a CPD event and you might write some notes for that, and you'd have a really good hour-long presentation, some great discussion, and then you disappeared off, everybody went back into practice, and there wasn't really any kind of follow-up. And I thought we need to do a little bit more. There's an opportunity to build a community here where we are constantly updating, creating, adding new content that people keep coming back to. So really, we want to provide people with a lifelong resource to support them throughout their career. And I feel satisfied that we've done that in creating Zero Pain Philosophy.
Yeah, I think that's, from my time in practice, I think that's really important, that knowledge that you have on a CPD is not forgotten, and you need some momentum, and to feel like you have other people around you doing what you're doing. And I've certainly been in that situation myself in practice. You get an idea and you want to support bringing a physiotherapist in, and you haven't got the practice on board because not everybody else went to the CPDs that you went to, and it's very hard to keep that momentum going. So yeah, I think creating a community is really important. And how have you found that that's been received then in veterinary practice, and like from the members that you've got?
We get really good feedback. I think what people like is that we are constantly producing new information. One of the things that I was always concerned about is I write notes. One of my bugbears is presenting a lecture and people want notes associated with it because the notes go out of date. And what I found with the website is nothing goes out of date, so we can constantly keep it up to date. Topics change, and actually, if I've recorded a webinar 5 years ago, that's out of date as far as I'm concerned, and we need to update it. And the same goes for notes. So I love the ability to keep things up to date, and that keeps people's knowledge on that particular topic evolving. We get requests quite a lot from people, right? I've heard this, can I have your opinion on this? And when we get lots of requests around a particular topic, that will then stimulate us to write one of our pain updates, which is on the website as pain under the pain news section. That's a free area for the website. So we will put a pain update together when we feel that there's enough information around the topic and enough desire for that level of knowledge. So we update those pain updates on a monthly basis. There's always a new topic there, so there's always something new for everybody in the pain world.
Yeah, oh, that's great. Yeah, it sounds like a really good resource to have access to. So you work out of EastCot referrals now, and how do you on a daily basis apply this to the patients that you see?
Where did the name Zero Pain Philosophy come from? I guess it is a philosophy. It doesn't mean that we should be aiming for no pain in every single situation, but our focus should be on pain and effectively managing pain. So thinking about how painful is that patient to start with, because that influences my anaesthetic plan. And we pride ourselves as anaesthetists on creating a bespoke plan for every single anaesthetic. So we'll take that patient's history into consideration from a pain perspective. We'll work out the best way to manage them. We do that by assessing the patient beforehand, and then we adapt that on an ongoing basis during the surgery. So if the patient's responding to a particular bit of the surgery, then we can adapt how we manage their pain intraoperatively, and then we'll manage that pain post-operatively through the use of pain scoring. And again, a huge amount of that is educating our colleagues. So educating the surgeons that might be operating, educating the nurses that are managing those patients in the post-op period, providing support for the nurses when they recognize pain. Okay, we've got a plan. Okay, what if we need to change that plan? We can adapt and flex and make sure that we do the best in treating the pain that is presented with that particular patient.
Yeah, okay. Are there any tools that you use to do your pain scoring that nurses might be using?
Yeah, so from an acute pain perspective, for dogs, we use the Glasgow Pain Scale. I would say that is the most common pain scale used in the UK. And for cats, again, we use the Glasgow Pain Scale for cats. The other pain scale for cats is the Feline Grimace Scale, which the Glasgow Pain Scale for cats was developed in around 2013. Feline Grimace Scale came along a few years later. Both of those are very successfully used. They're both validated, both very successfully used on a clinical basis. So dogs, Glasgow Pain Scale has been, when did we first start using that? That was around about 2005, 2006 that that was published. So that would be a UK situation. On more of a global basis, there are other pain scales. There is the Colorado State Pain Scale for dogs and for cats. I think people quite like those because there's a visual element to those. And then for cats, there's a pain scale called the Boticário Pain Scale, which is developed in Boticário in Brazil. We review those in some of our pain updates. So if anyone wants some information on pain scoring, if you just type pain scoring into the website, there's a review of all of those pain scores. And also there's a developed by a team at one of the universities in Brazil. There is an app called the Vet Pain app, and that's got all the pain scores in one place. So yeah, I guess in summary, pain scoring are the main tools that we're using on a day-to-day basis.
Yeah. Oh, that's really interesting. Yeah, especially if there's one place that you can get all of those pain scores. When I've used them in practice, like the Glasgow one, there is a bit of subjectivity between people recording or assessing. How do you find that?
We would always work on the premise that if you think the pet is painful, you should provide analgesia. So use the pain scoring tool. Very often we might be thinking, okay, let's say we're using the Glasgow Pain Scale. It's scored out of 20 or out of 24, depending on whether the dog's ambulatory or not. Let's say we score that dog as 3 out of 24, but the person using the pain score feels that actually I've just got a bit of doubt in my mind. I think that dog may be painful. That's where we need that understanding within the practice that in this situation, this is what we're going to do. Maybe rather than giving that dog its prescribed 0.2 mg per kg of methadone, according to our plan, we might say, well, if we're not sure, let's give 0.1 mg per kg of methadone and then come back and reassess. So the reassessment is really important there, that we do something, we make an intervention, and then we check that actually what we have done is effective for that patient. And we're really good at taking that individual approach. I always say that as a kind of shout out in the vet world. We take an individual approach. What do people say when they go into hospital? I was really painful and it took forever to get me any analgesia. So we do a great job at pain scoring and responding to pain in the vet world.
Oh, that's brilliant. Yeah, that's great. I know in the healthcare, human healthcare, there's the phrase of pain is what the patient says it is. And that for me really highlights how individual the feeling of pain, the emotion of pain, and the sensory input, how individual that really is.
Yeah, I mean, that is I love that. It's a Canadian human nurse. Her name has popped out of my brain at the moment. And that was it was in the 60s that she adopted that phrase.
Yeah.
And it's just all encompassing. Okay, probably, I don't know, is it easier in people? I don't know whether doctors would argue that it's easier and more difficult in people. Pain is whatever the patient says it is. We've always got that element that we are using a surrogate measure to assess that patient's pain. So we have to be the advocates in that situation. And I say, where there's that doubt, if we provide analgesia, I mean, in the acute setting, if we're talking dogs or cats and you're saying, okay, let's give 0.1 mg per kg of methadone, I don't feel that there are any adverse effects associated with that. So let's say we get it wrong and the patient isn't painful, actually that methadone is not going to be to that patient's detriment. So I don't think that's another big thing, is people shouldn't worry about giving too much as far as that's concerned.
Yeah. So always assume that the on the side of pain. Yeah.
We all have to sleep. We all have to sleep at night. We all know in the vet profession, probably sometimes our most worrying part of the day is driving out of the practice car park, thinking what's going to happen to my patients? Did I get everything right today? So yeah, we all need to sleep at night.
Yeah, absolutely. And then what about the chronic patient then? What's your approach there? Obviously, we've talked about an individualistic approach, but if you could kind of talk us through the pathway for a particular case that you've recently seen.
Again, I think the most important part is us getting a handle on that patient's pain. So assessment of the pain is really important, as far as trying to work out what is the impact of the pain. So I use pain scoring tools, actually one of the most important, relevant, easy one to use is a caregiver-reported outcome measure. So we talk to our clients, and we'll often get this information in the history when we start asking them questions. I mean, I often open the consultation with, what is your main concern from a pain perspective? And okay, I know if we're in a 10-minute, 15-minute consultation, we're taught to try and ask more. Well, if you ask an open question, that takes the whole 15 minutes of your consultation. So we've got to be really wary of that from a primary care perspective. We want to understand from the client what their concern is. And then in listening to that, we will often work out, okay, these are some behaviours that the client is reporting that they associate with pain, or behaviours that the dog has stopped doing, or the cat has stopped doing because they're in pain. So my cat used to be able to jump up to the kitchen counter, but now she uses a chair to get on the table on the chair, and then the table, and then on the kitchen counter. So clients won't realise that those are signs that could be associated with pain. So we just need to tune ourselves in to recognise those. If you can identify 3 caregiver-reported outcome measures in your consultation, that's the baseline for assessment. You can then think about whether we want to use a pain scoring tool such as the Canine Brief Pain Inventory if we're dealing with arthritis, or LOAD if we're dealing with arthritis. Let's say that first pain consultation, we want to understand the client's concerns. We want to understand what those outcome measures are that we should be focusing on. We can then give the client a pain score to complete before they come back for our next consultation. So we don't have to use a pain score in that first consultation. If we've got time and it's appropriate, then yes. But generally, I like to send a client away with one of those tools to complete. So we've got a baseline on our pain, but we've already captured those caregiver-reported outcome measures. And that is the basis for the future treatment. So any intervention we make, we want to know that's making a difference to those outcome measures that the client has defined.
Yeah. And how do you find that the owners respond to this approach?
Everybody wants to be listened to. So hearing what the client's main concern is, that is really important. I think if we ask our caregivers, and we know this, there's some work that Zoe Belshaw did at Nottingham about what clients with dogs with arthritis want from a consultation. They want our understanding, they do want our recommendations, they want to see the same person again, they want to know what the next steps are. And okay, some clients do want homework. So I think it's really important that, I remember my first job, I was always taught, okay, you don't know everything, you can't solve everything in the first consultation. Do what you can, get the clients to come back, because you can then follow up, you can re-examine the dog. Even if you think, hang on, what's going on in this case the first time, the second examination might reveal something different, something will change, you've had time to think about it, you've had time to ask somebody else. We know from Zoe's work that clients want to know what the follow-up is. So make sure we book them for that second consultation with us, and we know what is going to happen in that second consultation. So we say to the client, we are going to check in on those outcome measures that we talked about before. We are going to talk about whether the drugs that I've prescribed have made a difference, or whether there are any adverse effects. So setting out that treatment pathway for those clients is really important.
Yeah. Yeah, so it's an individualistic approach for the clients as well, as much as the animals that you're seeing.
Yeah, absolutely. I think if we're not clear with our clients, then they'll think, well, what was the point in that? And am I going to go back? And I often think back. I always use my cousin as an example. She has a tendency to rant a bit on Facebook. Oh, went to the vet. Vet told me dog had a bit of arthritis, prescribed some medication, paid 90 quid. What a rip-off. I thought everything was wrong about that. Everything was wrong. The conversation, the dog having a bit of arthritis, she's not taking that seriously. She can't see any value in what has just been delivered. It's so easy to get that right and get our clients on board.
Yeah, I mean, and I remember from my time in practice, a lot of clients just saying, he's just old. The dog is just old.
Yeah.
We don't need to treat. No, we don't need to worry about the fact that he's walking like this. And we can obviously see that this dog has got some issues. Like, no, the dog is just old. And I think we've come such a long way, haven't we, that we've got so many options available to us, whether that is pharmaceuticals or non-pharmaceuticals, nutraceuticals, physiotherapy, other adjunctive therapies that we can add in to make these dogs' lives more comfortable. So is there anything else that you add in? You mentioned that you use medications, but what else might you recommend for these dogs that you see, the chronic pain ones?
I guess arthritis is kind of our baseline example. It is the biggest cause of chronic pain in dogs, biggest cause of chronic pain in cats. So we very much use arthritis as an example of a multimodal approach to pain. And I always say to people, drugs are only a small part of it. Yes, I am an anaesthetist by training, so drugs are a natural part of what I do, but everything else matters. And if I'm giving a lecture on, okay, what are our second line drugs in arthritis management, the first slide is, we are going to talk about drugs, but we mustn't forget about all these things because everything else matters. The weight management is so important. The exercise management is so important. Physiotherapy, I'm a huge believer that a physiotherapist getting hands-on with that pet is going to make a huge difference. So there are a huge number of things that also make a difference, and just throwing drugs at the problem is absolutely never guaranteed, never going to solve the problem. So we do have to take a holistic approach and look at everything. We take I call it an evidence-informed approach. We don't have the evidence base for everything we do. However, we should take the evidence that we have, we should appraise the evidence, and then we have a lot of experience with using a lot of these approaches where the evidence can support that. So we should be as evidence informed as possible in our approach as well.
Great. No, that's great. So we talked about arthritis being kind of the bread and butter of what you're seeing on a daily basis, and it's such a common occurrence in our dogs and cats. What other conditions might you be seeing that display pain? So it's other than kind of the post-operative.
Yeah, so from a pain clinic perspective, I tend to see the weird and wonderful. I love an arthritis case because we've got a lot of information and we have some really clear pathways that we can follow with arthritis management. I tend to get some of a lot of cases that have a behavioural element, that have seen a behaviourist, and there is the question over whether this dog is painful or not. And okay, some of those dogs we can get hands-on and examine the dog, and other dogs we can't necessarily get hands-on. In some of those cases, we have imaging findings as well. So we might have an MRI or a CT to help us out. The key to all of those cases, well, the limitation is whether we can get hands-on with that dog or that cat, because physical examination reveals so much. So it doesn't matter what type of pain we're dealing with, we can understand the impact of that pain with our physical examination as well as our history taking. So those are the two most important things with any type of pain case. But yes, I do see cases from a behavior perspective, cases that may have neuropathic pain, so cases of syringomyelia in dogs, or feline orofacial pain syndrome. That's a fairly common neuropathic presentation in cats. So yeah, a whole variety of interesting cases. Again, the baseline is understanding from a history point of view, understanding the disease. So feline orofacial pain syndrome, physically, we may not be able to see anything. Examination might not be terribly useful in those cats, or limited in those cats. The history taking is really important to try and understand what those behavioural triggers are and where the anxiety is, because generally there is a behavioural trigger for orofacial pain syndrome. Understanding that, trying to manage that, and then trying to use what we know from the literature to guide our analgesic choices in those cases. Yeah, so generally difficult cases.
Oh, makes the job more interesting, doesn't it?
It
Yeah.
does.
So in your experience then, working with this philosophy, how does that affect the team that you're working with? Do you notice a difference from, you know, your time in kind of first opinion and mixed practice to now with this philosophy?
I think that's probably an easy one on a day-to-day basis. I think working in a referral hospital, we have people work that we've got anaesthetists that have grown up and trained and have a deep knowledge of pain understanding. So it's almost a given that we're taking an optimal approach to pain management there. I guess on the other side of that, and I guess what's a little bit more inspiring is hearing the stories from our zero pain practices in the journey that they've come on, coming from a primary care setting. So most of our zero pain practice is really designed for primary care practices to demonstrate their analgesic excellence. And what I really love is seeing the journey that those practices have come on. So the difference that education sessions can make. So we got the team together, we talked about pain scoring, or we talked about opioid administration. We ran an audit, we saw how our uptake of pain scoring increased, our patient comfort levels improved. The stories from the clinical audit are some of the most inspiring things that we see. And that's why we're here, really, is to inspire people, drive change, increase analgesic excellence, support those people in practice, support those champions in practice. So there's always a little voice in every single practice saying, can we please do a better job at pain management? And it just takes that person to go to convince whoever they need to convince to say, actually, we want to start on the road to becoming a zero pain practice. And that's lovely. That's really cool to see.
Yeah, yeah. And you mentioned clinical audits there, and I think that's certainly a something that's developed quite a lot in like the last 5 years. The RCVS Knowledge website has guidance on how to do a clinical audit. So if there's practices out there who are wanting to do one, I think that's a great resource. Are there other resources that you've used to direct people to doing audits?
I'm a big fan of not reinventing the wheel, and I have used RCVS Knowledge myself. So we direct our practices to RCVS Knowledge as the basis for this is an audit template. This is how to set up an audit. What we are going to start doing is publishing the audits that people have done for their zero pain practice accreditation. We're going to have a page on the website where we publish those, because some of them they're so valuable, they're really inspiring. There's a lesson for every practice in audit. So if someone sat here thinking, oh, I'm really wanting to get into audit, but it just seems a bit too much. Audit is dead easy. You assess something, you put a change in place, and then you reassess it at an appropriate time period later. It doesn't have to be complicated at all. So yeah, audit is not challenging. I think what's really helpful is seeing examples of what other practices have done and thinking, right, could we do the same?
Yeah, yeah, absolutely. And it's a really good way for, if you are that little voice in a practice, to be able to convince the decision makers that actually this is what's happened over time, and this is how, you know, we've put this in place. This is what's happened. Now, can you take this seriously and give us some more support? Yeah.
Yeah, definitely. In a practice, you could have 6 people in a practice, or you'd have 60 people in a practice. There's potential in every single practice to find a topic that we can audit. Everyone has an opinion at the start of an audit. Oh, it's going to go this way, it's going to go that way. Actually, we need to get some numbers, or we need to get some data and make our decisions based on that data.
Yeah. So speaking of RCVS Knowledge, I hear that you received an award for quality improvement and an anaesthesia safety tool in 2022. So can you tell us more about that?
Yeah, so the inspiration came from I was learning to fly at the time. I haven't, that kind of stopped in COVID. COVID was a really difficult time to learn to fly. The British weather is a really bad factor in learning to fly. And then you combine that with COVID and it just turns into a real pain. And I just haven't had the time in my life to pick it up since. But in the world of light aircraft and actually in commercial aircraft as well, there's a tool called NOTAN, so Notice to Air Persons. I say air persons. It used to be airmen, NOTAN, but being politically correct, that's an air persons, I believe, is the term now. This is a checklist. It's not a checklist. It's a notification. So before you plan your flight, it's a notification that tells you these are all of the things that could potentially impact your route. So maybe this airfield is closed, so you can't have that as part of your plan. If you need to divert somewhere, you need to know this airfield is closed. And I thought, okay, well, it is quite a cool communications tool. How can we adapt that to the anaesthesia world? Because there are so many things that cross over between the airline industry and the medical profession, checklists being the main one. I thought, how can we adapt this? So I thought, okay, let's call it NOTAN, Notice to Anaesthetists. And let's create a communications tool for teams that are, you've got an anaesthesia team. We typically have people that rotate in and out. So that might be interns, they rotate every 8 weeks through anaesthesia, or it might be multidisciplinary nurses that rotate every 6 or 8 weeks through anaesthesia. A lot can change in that time. And what I wanted to do was make sure that when those people have their first day back on anaesthesia, they're completely aware of anything that's happened over the preceding weeks. So have we had a protocol that's changed? Have we got a piece of equipment that's off for repair, or have we got a new piece of equipment, or are we using a different brand of the same drug? So it's really common to switch between brands of methadone or fentanyl, for example, and some of the packaging looks a bit similar. And it's really a common source of medication error is people picking up the wrong bottle and drawing up the wrong product. So it's really important to say, right, okay, this month we were using this brand, but now we're using this brand. The NOTAN, it's an A4 sheet, which is stuck up in the prep room, and also it's circulated on Teams. So anyone coming onto that service can have, it's a 5 minute, well, it's not even a 5 minute read, it's probably a 2 minute read. On the Monday morning, when you first come back onto that service, you just go through the NOTAN and you can see if there's anything that's changed that you should know about before you start your week or your 2 weeks on anaesthesia. And we did, to measure the impact of that, we surveyed everyone in the team. This is when I was at Anderson Moores. We surveyed everyone to ask about their confidence level in anaesthesia, and then 8 weeks after implementing the tool, we resurveyed them, and we showed that people's confidence in coming onto the anaesthesia service had increased by use of this tool.
Oh, that's brilliant. That's really inspiring. And it doesn't surprise me that you learned to fly. I think that or you're learning to fly, that checklist approach of safety is something that's been, it's heavily ingrained in the aviation industry, isn't it? And that's where we initially got all our checklists for anaesthesia and surgery protocols, isn't it?
Yeah, and we are evolved. There are anaesthetists evolving that as well into not just checklists for before we start the procedure or when we finish and check out, but okay, I've had something go wrong. My patient is hypotensive. This is the checklist that I work through to make sure I've not forgotten anything. It's just this recognition. I think when I was at vet school, there's just this expectation that you should be able to, you're a clever person, you should be able to load all this stuff in your brain and keep it in your brain. We're human. There's absolutely no way. And in an intense situation like something going wrong in theatre, you can't remember all those things. We get stuff in the wrong order. So we definitely need checklists. And you can imagine an engine failure in an aircraft demands exactly the same cognitive load. So yeah, you need a checklist to make sure we get everything right.
Yeah, perfect. So there's lots of tools there that we've talked through that are available for vets to use. But how can vets get involved with the zero pain philosophy?
I guess the first step is to head over to our website, explore what is available. If you want to access the pain news section, we do have to capture your email address because we're a site for vet professionals. We're not a site for pet owners. So that's the reason why there is the sign-in part of that, just to keep us comfortable from a regulatory point of view. But please dig into the pain news section. Please listen to the podcast. We've got a podcast available on Apple and Spotify, and we've got our nerve block videos. So those are all the free parts. If you want a little bit more than that, then we've got our webinars and we've got our accredited courses as well that you can subscribe to. So yeah, everyone's welcome.
Great. Well, I'll put the website address in the show notes, but it very simply is zeropainphilosophy.com. So very easy to remember. So I like to close my podcasts with one question to my guests, which is, what 3 things would you like listeners to take away from this podcast today?
I think the first thing we talked about was pain score and intervene, and then reassess with acute pain. For chronic pain, capture those caregiver-reported outcome measures. So we've got a really clear objective. We know what matters to the client. We know what they've told us. We're going to measure our interventions against that. And then for both of those situations, have a plan B or plan C or plan D. Often in chronic pain management, we end up at plan D, but we always need a plan B to start with. Just buy yourself some breathing space by working out what you're going to do next.
Oh, brilliant. Thank you. Well, I've really enjoyed talking to you today, and I hope our listeners enjoy this podcast as well. I will put any resources that we've talked about. I'll try and put links in the show notes so people have access to those. And yeah, just a big thank you for joining us.
Thank you ever so much. It's been a pleasure.
Great. That's wonderful. Please keep an eye on our social media. Our podcasts are available on Apple and Spotify, and we always post about our latest podcast on our social media pages. Take care. Bye-bye.
Thanks for tuning in to the Nupsala podcast. This is one of many insightful episodes that we have in store for you. You can stream the episodes on Spotify, Apple Podcasts, and Amazon Music. Simply search the Nupsala podcast. You can also watch on YouTube or directly at nupsala-learning.co.uk. If you'd like to stay up to date with all our latest content, please follow us on social media, where we always post when a new episode launches. All the links and details are in the bio. Thank you.